Hi, I'm Dr. Felice Gersh, your integrative OBGYN, here to discuss with you a very important topic for every woman. And I'm going to focus on this topic as it relates to perimenopause and menopause, but it actually can be a significant issue in women postpartum and in women on oral contraceptives. But we'll talk about that another day. Let's get back to perimenopause and menopause and the subject at hand, which now for a few years has had a new name called genitourinary syndrome of the menopause. Now, that is a more encompassing term to include the changes that occur in a detrimental way to the urological structures involving the lower urinary tract, the bladder and the urethra, and the vaginal tissues, which are not just the superficial layer, but the whole group of tissues that involve the vaginal and pelvic floor. So we want to focus on how we can use vaginal estrogen to actually help maintain the health and function of those really critically important structures. They're very important, and not just for sexual activity. We'll talk about the importance of these structures to the global health of women. Well, like every single structure in the entire female body, there are estrogen receptors. They're present in every layer of the vaginal skin. And we're going to talk about what is the vagina anyway. I gave you a clue. It's skin. And the urological structures that are in close proximity to the vagina. They all have estrogen receptors. Now, there are other medical treatments for vaginal changes that occur with the perimenopause and menopause, and we'll talk about them another time. We're going to focus right now on estrogen, and I'm only going to focus on estradiol because we know estrogen is not a hormone. It's a family of hormones. I am going to, in future episodes, talk about the use of estriol, E3, and vaginal health, and also DHEA, that's an predominantly adrenal steroid, that's an androgen, and its use, but not today. Today, we're going to focus on estradiol, the estrogen made by, of course, the ovaries. Now, as we all know, ovarian production of estradiol declines, although erratically at first, in the perimenopausal time of life, and then just stays low forever. The ovaries can no longer produce any estradiol after all the eggs are gone. It's the end. Okay, so what are the consequences for the vaginal tissues and the bladder and the urethra? Well, they're not good. We always used to call the vaginal part, and we still do, vaginal atrophy, or we would include the vulva, which I didn't touch on, but I am going to bring it up now, the external tissues to the vagina, the vulva. So we would call it vulvovaginal atrophy. Now, that's still included under the umbrella term of genitourinary syndrome of the menopause. But this was a wise thing to include the urological structures because they're so often forgotten, especially sometimes by gynecologists. Of course, not by urologists, who, by the way, are very on board with vaginal estrogen, estradiol, and I'm not going to talk about Premarin. I never use Premarin, so I'm just not on my menu. We're not going to talk about Premarin. There is a Premarin cream. That's as much as I'm going to say about it. But let's talk about estradiol. It comes in 3 different modalities for delivering this important hormone to those tissues. It's a ring, okay? And the brand name for that is Estring. And it delivers a very small amount daily. And that is one reasonably popular, but not as popular as it might be because it's not covered by very many insurances. So it's quite costly. Okay, then what else? Well, there's the estrogen estradiol cream, and the brand name for that is Estrace, but it's generic now, but often we still call it Estrace. That's the brand name for estradiol cream. And then there are some inserts, and there's 2 types of that. One is predominantly generic, and that is what was branded Vagifem. We'll go back and talk about the dosing of these products. And there's one other, which I'm not going to talk about either, because that's not as commonly used. So let's just talk about these. Okay. Well, let's talk about the cream, the estradiol cream. What is the dose? The dose is very tiny. It says on the label 0.01% estradiol cream. So let's talk about that in milligrams, because most of us are not thinking in percents. What does that mean, 0.01%? It's zero point 0.1 milligrams. That is a very tiny dose. What about for the suppository that is Vagifem? That is 10 micrograms. Now, I don't know if you remember your, dealing with these kind of percentage and changing them from when you're dealing with micrograms into milligrams, because the vaginal estrogen cream, the estradiol cream, is dosed as milligrams on the label. It would be 0.01%, which is 0.1 milligrams. And this little suppository, like tablet, it is 10 micrograms. That is 0.01 milligrams. That's a really, really tiny dose. Now, how are these recommended to be given? A loading dose, which would be every night for 2 weeks, and then just twice a week, just 2 times a week to put these products in the vaginal canal. Now, the loading dose is supposed to sort of get things going, and that's a good thing to get things going, but the dose is really tiny. Now, what about some of the data? Well, I was reading about some of the data on the little tablet, which, by the way, I virtually never use unless someone forces my hand and they say, I just won't use any other product. And I'll tell you why. Because the data on it is not very good. When this product first came on the market, the dose was 25, not 10 micrograms. But it turned out there was a little bit of uterine stimulation to the lining in some people, and they dropped the dose to 10, and that's what's available now. But this is a very tiny dose. What about the efficacy of such a tiny dose? It actually isn't very good. They talk about it in the articles that are published, statistical benefit. That doesn't say how much benefit. It just means statistically, this is all statistical gamesmanship often, that it did better than placebo. So let's talk about what is this statistical benefit. Well, if we look at maturation of the lining cells so that they're not superficial cells, that rather they are superficial cells instead of basal cells. They're more mature, and it shows the estrogen effect. Well, it's not very good. After like 12 weeks, it only showed like 13% improvement. It's only 13% were actually showing that they were at where they should be. So it's not very good. And in terms of statistical benefits, they're very low. And often you don't see any change or difference between the placebo until you get out 3 months before it meets any statistical benefits. So it's not such great shakes. That's the thing. The benefits often when they compare it to placebo are, well, after say 12 weeks, there's like a benefit in pH. So the pH is more acidic. So the normal pH of the vagina is 3.5 to 4.5. So in the study, you had a pH below 5. Now remember, that's not even right. It should be lower than that. But even then, the pH of 5, below 5, wasn't that different until you got out for a very long time, like 3 months or longer. And even then, it only was really statistically beneficial in about half the women. So the bottom line is that there are women that will be benefited, but it's not great. That's the thing. It's not so great. So my personal preference is to use the estradiol cream. Here's the problem. In one set of studies, what did they find? By 30 days, half of the women had stopped using it. And why did they stop using the cream? Because they hated using the cream because it's so messy and unpleasant to use. So what's the standard use? Well, it's a cream and it comes with a little syringe applicator. And most commonly, the dose would be 1 of the little milliliters, okay? So it's only a milliliter, okay? And how much cream would be in that in terms of milligrams? 0.1. So it would be 0.1 milligrams, which equals 1 milliliter, because that's the concentration, 0.1 milligram per milliliter, which is also equal to 1 gram of cream. Don't worry, there's no test on this. And that would be inserted intravaginally every night for 2 weeks straight consecutively, and then just twice a week. So basically, this is like inserting a blob of cream into the vagina twice a week forever. Okay, forever. Because you will never get over this vulvovaginal problem. The vulvovaginal syndrome is never going to be aged out. It all will stay forever. So if you're not on a physiologic dose of estradiol, and even if you are, it still may not be enough to maintain everything just right. And we're going to talk a little bit more about what is happening during this vulvovaginal atrophy as a subset of genitourinary syndrome of the menopause, and why treating it prophylactically, getting ahead of it, is so important. So in terms of the treatment with the cream, it is darn messy. Basically, you take a syringe and you insert I call it the blob. You insert a blob of cream into the vagina, half of it falls out, and it's like, if you want to have a relationship with a partner, it's like, it's messy. I mean, it's not supposed to hurt him. It's a very tiny dose he can wash off, but it's like not pleasant. And it makes all the underwear all messy and wet. It's just, nobody wants to keep doing it. Like when you have a data set that shows half the women stop using it after 1 month, that is a terrible success rate. So what do I recommend? Well, first of all, who came up with the idea that women would think it's okay to just take a blob of cream and stick it up there twice a week, when half of it comes out the next day or so? Well, I looked it up because I thought, who the heck came up with that? Well, I couldn't find anyone to blame in particular, but what they came up with wasn't much. They simply said, well, it's designed to just be absorbed over time. Well, of course, some of it, into the skin. They don't want it to be absorbed into the bloodstream. But so, of course, it can help. It turns out that on skin, even a little bit of estradiol is beneficial. But remember, I just told you that when you put in that little suppository, that is 0.01 milligrams in that little suppository. They call it an ultra low dose. I call it a ridiculously low dose, okay? Come on. We want actual benefits. We don't want to treat it. Some of the treatments, even at 1 year with that little tablet, was not anything to brag about, even after a year of use. So the statistics on the tablet, not to be bragged about. A little better with the cream, but it's of zero benefit if people stop using. And I will talk about other treatments that have come out, mostly because people won't use the cream because it's too messy and yucky to be doing this for the rest of your life. Things like laser treatments and radiofrequency. Another day for that. Back to the estrogen cream. So I looked up, I tried to find, why did they even come up with this kind of a crazy arrangement? So it just seems like, I think that people thought, probably some guys, that women would be too intimidated by their vaginas and they didn't want to stick their fingers up there. Well, guess what? I mentioned it already. The vagina is just skin, okay? Like if you did a biopsy of it, it would be squamous. So what's the difference between the skin of the vagina and the skin on your arm? It's not that much different. Okay, the skin on your arm has the keratin. Like if you ever had like a loofah or a rough washcloth and you rubbed on your skin when you were like having a massage or some kind of skin treatment and this whitey stuff comes off, that's your keratin. Okay, so that is not in the vagina. What else is different? Hair. There's no hair growing in the vagina, thank goodness. So there's no hair, there's no keratin, but otherwise it's just skin. There are no glands. There's no glands at all. It's just skin. And the coverage of the cervix is squamous, it's skin. It's only when you get up into the canal of the cervix and then into the uterine cavity that you have glandular tissue. That's not part of the vagina. The vulva, the outside skin, is also skin. It's just squamous tissue. So all squamous tissue has estradiol, estrogen receptors. And just think of it. If you had dry skin or some kind of skin condition on your arm, would you take a blob of the medication cream and just blob it on? I don't think so. I think you would rub it in. Now, I don't mean rub it in so you're rubbing off the skin, not harsh, but, gentle, like rub it in until there's no blobbies and it's just invisible. You just rub in the cream and then you have your arm, your skin, okay? It's skin in the vagina. Let's just do the same thing. So, but you don't need as much because when you put it in the 2 times a week, half of it is coming out, okay? So that's really wasteful too. So it's a little bit of experimental. So let's talk about the vagina, like the size. How deep is the vagina? Well, if you look at my finger here, it's about like that deep to the cervix. And if you go all the way to the fornix, the area around the cervix, let's remember here's the cervix sticking down in the vagina. Here's your pretend cervix in your pretend vagina. And you have the length of the vagina with up to the cervix would be about that long. And if you add in the sides going up next to the cervix, it's like maybe the size of my finger like that. You can do it. You just either take maybe half the amount of cream, half the amount that you would put in when you put in the blob, which would be 1 milliliter, like maybe make half that amount. And you could take a milliliter and just press it onto a plate and then take a toothpick and divide it into 2 piles and then try it. Just take how much cream does it take to just put it in the vagina and just gently, I don't mean like rub off the tissue, just gently rub it in everywhere. And then some around the opening. Remember, there's estrogen receptors on the vulva too. So around the opening and around the urethra, but not just around the urethra, but the whole thing. And just gently rub it in. You know what you don't get? A mess. There's nothing coming out because it's just rubbed in. If you put cream on your arm, you could put your clothes on. Nothing's coming off. You're not like messing up everything. And also, when you use your progesterone vaginally for the 2 weeks, you can put the estradiol cream in the morning. No mess. It's just fine. And it's just very neat. And you use about the same total amount of estradiol cream, but you would space it over several days. You could do it for 4 days, 5 days. There's no magic amount. Now, I'm saying to use this and rub it in gently. What if you have had breast cancer, you're on breast cancer treatment? I want to make sure you know that in terms of systemic absorption, if this is an issue, that we're not talking about breast cancer, but if you have an oncologist or another doctor and they don't want you to have blood levels, what we call systemic levels, we have no data. We have very little data on anything, but we have no data at all on if you gently rub it in using about the same amount over the course of a week, but you're spreading it into multiple days and just gently rubbing it into the tissues. We have no data. So if that's the case, please use it the standard way, which would be 2 of those 1 milliliter blobs twice a week, even though it's so messy if you're going to use that, and talk to your doctor because I remember I'm not giving you personal advice because I'm not your doctor, okay? So I'm just giving you general information. But so if you're not worried about a little bit of systemic absorption, which I don't have a problem with, I'm giving people hormones anyway, the amount of blood increase in terms of the level in the blood, because the dose is so tiny, is really tiny. It's obviously in relationship to the dose that you put in, how much gets into your bloodstream. There are some people that say, oh, if you put it in the vagina, it doesn't get absorbed. Yes, it does get absorbed. Of course it gets absorbed because anything you put in your vagina or put on your skin anywhere, some of it will get absorbed. It's not going to be the same for everyone, and it's probably less as the skin of the vagina gets healthier and thicker because the skin is supposed to be a barrier. It's not supposed to let stuff through. So the healthier your skin in the vagina gets, probably less will be absorbed systemically. But I'm not worried about systemic absorption in my patients that I'm giving systemic doses because that tiny bit of extra in the blood is going to be invisible anyway in terms of any systemic function changes. But I'm not worried about that. It's only if you're in a situation where you're told you absolutely don't want to have systemic levels rise, then please follow the directions on the package. Okay. Don't take my advice and talk to your own doctor because we don't have data. I repeat, we don't have data on how much of it gets absorbed when you use it in my method where you gently rub it in. And I'm not the only one that's recommending this because when you think about it, how ridiculous it is to think that any woman's going to forever put blobs of estrogen cream into her vagina and then have it halfway, blob out. It's just not sustainable lifestyle. And it is really, people worry about it, even though it really isn't a worry about their partner if they're having sexual activity. What is all this estrogen cream doing to him? He can just wash it off. But the bottom line is no guy really likes that idea. So even if it's not going to do much of anything. So why is it so important? And I mentioned you want to have maturation of the cells. You don't want to have all these like basal cells that we call them. You want to have the right pH. You want to have all of these things happen. And they're not happening great with the tablets. It's better than nothing, not so great. Better with the cream. But the thing is that it's so important to have these things addressed because you want to have the right microbiome, the collective of microbial life forms in the vagina. It's really important for the health of the bladder, even if we won't talk about the vagina the second, we'll come back to it. But what about the bladder? Remember, they called it now genitourinary, like is urinary tract. Well, the bladder, when you don't have enough systemic estradiol, it becomes altered in ways that increase the risk of bladder infections. Now, bladder infections are not just unpleasant when you have a lot of burning and urgency and frequent urination. They're actually risky. Women can get urosepsis. That's where the bacteria in the urinary tract, and it could be through the urethra, it could be if it rises up to the kidneys, and can be even from the bladder itself, can pass through the walls of these tissues into the bloodstream and create sepsis. That's where you have bacteria circulating in the blood. And urosepsis, that means urological etiology of sepsis, septicemia, can actually cause septic shock. And it's very dangerous, especially as we get older and our immune systems suffer immunosenescence, aging of the immune system. Of course, estradiol should help that. But we're still aging. Remember, no matter how I give hormones, I'm not turning anyone into a 21-year-old, not happening. So we are going to age. The whole goal is to age better and age slower. We're just trying to kick the can down the road. So whatever bad stuff is going to happen, it'll happen 20, 30 years later than it otherwise would have. So we don't want urosepsis. And by age 70, guess what? 50% of postmenopausal women not on any hormones, they will have colonization in their bladder. They'll have abnormal growth, usually from bacteria coming up from the rectum, like E. coli, Klebsiella, growing forever in their bladders, like they're like freeloaders. They're just camping out there. And they came and they're settling into the bladder, and we don't know how to get rid of them because it's colonization. And it's not considered an infection that needs to be treated unless there are symptoms. But it can turn from colonization into an infection at any time, and there's always the risk that the bacteria can leak into the bloodstream or rise and create a kidney infection. So we don't want this. We don't want gut bacteria from the colon living in our bladders. So that is bad. In addition, what about incontinence? Oh my goodness, I cannot tell you what percentage of women have either urge incontinence. That's where when you gotta go, and you often can't get to the bathroom on time, and it just comes out and you get wet from your own urine. Or stress incontinence, where you cough or laugh or jump or want to play a game, trampoline, play with your grandkids, whatever, and The urine just comes out. You can't feel it coming. You can't know it just leaks out. And many women have a combination. We call it mixed incontinence. They have aspects of both urge and stress. Well, there's now data published that giving vaginal estradiol cream can actually help and help reduce the development, and even when it exists, can reduce it. But early onset, which we're going to talk about being very proactive and starting early, it's much easier and more successful to prevent than to treat. Prevent a problem rather than treat the problem. So we want to think about the urological part of genitourinary tract syndrome of the menopause in terms of bladder infections and also different forms of incontinence. In the vagina, let's go back to the vagina. We want to have healthy vaginal microbiomes. We don't want to get infections. So postmenopausal women are more likely to get bacterial vaginitis, what we call BV, bacterial vaginosis, where they have a lot of anaerobic bacteria which prefer an alkaline or basic pH, not an acid pH, and they take over. That is not good. It's not healthy for the tissues, not at all. And so we don't want to have that. And of course, women who have vaginal atrophy, vulval vaginal atrophy of the menopause will often have terribly uncomfortable sex because penetration becomes really, really painful. The tissues are not only dry and irritated, but they're actually constricted. The whole vaginal canal becomes narrowed. The opening, what's called the introitus, becomes narrowed. And because estradiol is important for all the different layers, including the connective tissue underneath the superficial layer called the epithelium, things like we talked about with connective tissue, the elastin, the fibrous tissue, the collagen, they are not made properly and they disintegrate. So you end up having less stretchiness. So the vagina, which can be amazingly stretchy, remember babies, a whole baby head this big can come out of a vagina in a pregnant woman because of the hormonal changes. Well, we're just trying to have, like, say, a woman normal sex. It's too painful. And then they have to go to pelvic floor physical therapy. They have to have dilators, all kinds of treatments. And we don't want to have to get into that. We want to be preventative. And so what about the other things that happen? How about prolapse, where you have what are basically hernias, where the bladder can push down, it like herniates into the vagina from above. The rectum can herniate into the vagina from below. The bladder we call a cystocele. When the rectum pushes up, we call that a rectocele. You can also have poor connective tissue, and the whole uterus starts to descend. So we call that descensus. And if the whole uterus is actually starting to poke out the bottom of the vagina, then that's prolapse. Nobody wants to feel their uterus between their legs. Okay, this is real. Believe me, I have seen the entire uterus coming out the vagina, like, shoop, it just falls right down. We can help to be very heads up preventative for these really unpleasant things. I know that we have some lovely doctors who are urogynecologists, but I don't want to give them any business. Not my patients. I'm not having them go there. Not if we are proactive and we start hormones early so the tissues stay healthy. We don't have to try to do repair. So when should you start these very vital estrogens? And like I said, I prefer the estrogen cream. Oh, I didn't mention the ring. The ring is fine. It's a very small dose too. And so it's not a big dose. It's a very small dose. And some women find it very useful because there's not the same mess. There's no cream at all that comes out. But remember, the way I recommend it, there's also no mess. And it is a dose that is really small. It's in the same neighborhood as on a daily basis, how much you get, to the little suppository, the little tablet, like the Vagifem. I'll just mention for a second the Imvexi. That's the other suppository. I hardly ever use that one. It's more like almost like a little gel tab, but it's also in the similar dosing family. These are, to me, remember, they're ultra low dose, and to me, they're insufficient. The data shows that they're not that different from placebo for a very long time, and they are better than nothing. I'm not going to say they're not, but I don't think they're up to the task. Okay, I think they're too low of a dose for my taste, for what I want to achieve. So the cream, although a very low dose, remember I told you, in 1 milliliter, which is 1 gram of cream, it's only 0.1 milligram of estradiol. So it's a very tiny dose. It's just not ultra low. It's low, but not ultra low. Okay. So we definitely want to start early. So when is it too early? Well, it's never really too early because it's not going to do any harm. It will never do any harm unless you're one of those unusual people who has an allergy or something to the cream. And then we have to go through a compounding pharmacy to get a different cream base. But that happens once in a while, or sometimes people don't like the cream base, and then you can get a compounded version that has a different cream base. Okay, so that's totally fine. But remember, the perimenopause starts 10 years before the official menopause definition, which is 1 year, no bleeding. So we never know exactly when that begins, but all women are going to be in perimenopause by the time they're in their late 40s. And since the typical age of menopause is 45 to 55, and menopause as a perimenopausal state starts a decade before that, if you figure the vast majority of women are going to stop having periods by age 55. There are some 56, 57, 58, but the vast majority will be in official menopause by age 55. If you start the vaginal estrogen cream and you use it, maybe you rub it in like 4 times a week at bedtime or in the morning, and you're only using about, half a milliliter at a time, whatever it takes, but in that neighborhood, and you use it those few days a week to help maintain the tissues, and you start around age 45, or if you have an earlier history in terms of your family history, if your mom went into menopause at 48, maybe you want to start at 40, okay? So there's no danger. I want to make it clear. What's the danger? There's no danger, okay? Remember, the amount absorbed is insignificant, and unless you're in a situation where you're prohibited for some reason from having any additional levels in your blood, it's a drop in the bucket, okay? It's not going to have any significant impact on your blood levels, but it can have a significant impact on the health of those tissues. We don't want to give business to the urogynecologist, and some of them are my friends, but I don't want to give you any business, sorry. I don't want my patients to have incontinence, bladder infections. I don't want them to have prolapse, descensus. I want my patients to have as good a sex life as possible. I don't want them to have vaginal infections. To do all of that, to have that accomplished, start the vaginal estrogen cream early in the perimenopause years to be proactive and prevent genitourinary syndrome of the menopause.